We move on to the next session, that is a treatment of refractory anemia in CKD with the HIF-PHIs. And we have Dr. Dinesh Khullar from Delhi who's going to join us online.
Well, thank you very much for this wonderful opportunity. Am I audible?
You are in Goa and yet you are not here inside the auditorium.
So my on one hand, sincere thanks to Dr. Umesh Khanna for this wonderful opportunity. And Dr. Khanna, please forgive me this time for letting you down because of some compelling reasons I couldn't. But I've tried to give the flavor of Goa to whosoever is watching the proceedings. I think the only mismatch is my tie doesn't probably go with the background, but my sincere apologies once again. So I am going to talk about refractory anemia and where do we stand in 2023. Well, are the slides visible and moving? Yeah. Right. So we'll begin with a case. Dr. Khanna, am I audible? Great, thanks. So I'm talking about a 20 years old male, 55 kilos, diagnosed as VU reflux, secondary to posterior urethral valves, and got initiated onto hemodialysis in 2020. And sometime back, the lab parameters were not very impressive. He was complaining of symptoms of fatigue, listlessness, etc. And hemoglobin has been persistently low. At this point in time was 7 grams, and there was a history of repeated blood transfusions. He's been was put on erythropoietin, and the dose had been escalated to 6,000 units 3 times a week. And this was the iron profile, where, as you can see, the TSAT was 36%. The serum ferritin was very high, and adequate B12 and folate levels. So how do we really proceed in this case? Do we need to give more iron in the face of ferritin levels, which are already very high? Should the dose of ESA be increased? As you can see, he was already receiving more than 300 units subcutaneous of erythropoietin for quite some time. Is this what is referred to as refractory anemia? And well, do we need to give more blood transfusions? Let's recapitulate. And this august audience here doesn't need any further knowledge about the role, the various pathophysiological factors going on to cause anemia. Just to recapitulate, we know there are beyond iron deficiency reasons which have foxed us over the years, especially systemic inflammation. And we have over the years realized the importance of hepcidin, which was not allowing the iron to be effective. And this is what we have realized was the main villain. Well, moving on, it's been a long journey from practically nothing to offer to these patients beyond blood transfusions. We were lucky to have the availability of intravenous iron. And then, of course, the game changer was erythropoietin. And I still remember when, during the course of Asia Pacific Congress of Nephrology in 1992, under the stewardship of late Professor Chugh, the first erythropoietin of the country was launched way back in 1992. And improvements in the form of darbepoetin, in the form of sera. And then finally, we have recently been excited about the potential role which HIF-PHIs can play. Before moving forward, we can't ignore the role played by iron. We know that we have to differentiate between the absolute iron deficiency, where we have to focus on repletion of iron stores, from what is quite common in our patients, and that's the functional iron deficiency, which again could be related to an iron-restricted erythropoiesis, which means the ferritins are there, the stores are replete, yet the iron requirement for the kind of erythropoiesis is not available, and we probably would need to maintain higher TSAT in these patients. But what is frustrating and has proved quite a big challenge for us over the years is the iron sequestration and the role played by chronic inflammation, whereby hepcidin acts to sequester iron by inhibiting the absorption of dietary iron from enterocytes or the iron efflux from hepatocytes. So thereby, even though the ferritin levels are normal or elevated, yet the patient has a perpetual problem of anemia. Is oral iron the way forward? Well, we have realized that, well, this was not, and there are, of course, the advantages of oral iron, but the iron transport and storage is dysregulated in CKD, and besides the frequent GI upsets caused by these, the absorption is not what we really aspire for, and hepcidin is certainly another problem which we always have faced and have reiterated. Well, we got excited when we realized that parenteral iron could be the way forward, and that's why we realized its importance, because it eliminates the GI absorption. There's a rapid incorporation in RBCs, and fewer administrations are required to reach the target hemoglobin. But then it typically had its disadvantages. We have improved upon the hypersensitivity reactions, and that's what has really given us the opportunity to successfully use iron sucrose, ferric carboxymaltose, and as well as iron isomaltoside recently. And we have raised the bar, and we have gone higher and higher as far as the ferritin levels are concerned. And we know this pivotal trial, that's pivotal clinical trial, where we try to see whether we could go as high as ferritin levels of 700 micrograms per liter. And it was concluded that the high dose of IV iron, rather in the proactive arm, rather than the reactive arm, this resulted in a significantly lower risk of deaths or major non-fatal cardiovascular events as compared with that observed with a reactive, a low dose regime. So we got excited, and we have, as I said, raised our bar, and we want to achieve a higher ferritin levels to give the maximum advantage to our patients receiving intravenous iron. And that's how pivotal with iron sucrose, and subsequently more and more trials with ferric carboxymaltose or with isomaltoside have shown us that intravenous iron could be the way forward. However, as I said earlier, the game changer, as we all know, was erythropoietin when it first became available to us. And over the years, we have moved on from the original erythropoietin to darbepoietin subsequently, as well as Sera. And of course, a few other molecules are going to be available, hopefully, in the future times. And this is how we typically use erythropoietin or darbepoietin or Sera in our patients. There are landmark clinical trials which told us that do not attempt to go or achieve very high hemoglobin levels with the help of erythropoietin, because this can give rise to high rate of thrombosis, high rate of strokes, and we can be in trouble if we try to achieve hemoglobins more than 13 grams. So that's why we have our target set between 10 and 12. But achieving that is something which we always want to go in for. But many of the times we simply fail, and we are not able to achieve the kind of target hemoglobins which we typically want to. So that is when the concept of refractory anemia comes in, whereby a large ESA requirement is there, which is defined as a requirement of excessive doses during initiation of therapy, or inability to achieve or maintain target hemoglobin levels despite the large dose in the iron replete patient. So first of all, you have to make sure that your patient is iron replete. There have been various definitions from the EPBG, the NKF-KDOQI guidelines, or the KDIGO guidelines, but we generally believe that if you are having to use more than 300 units per kilo per week of erythropoietin subcutaneously, or more than 450 milligrams intravenously in a given patient, or in the case of darbepoietin, more than 1.5 micrograms per kilo per week, then, and to achieve a hemoglobin level between 11 and 12, you're probably dealing with a refractory anemia. And KD code also defines that either the initial hyperresponsiveness as having no increase in hemoglobin concentration even after first month of appropriate weight-based dosing, or an acquired hyperresponsiveness which occurs subsequently, which means that given patient requires 2 increases in ESA doses up to 50% beyond the dose at which the patient had originally been stable, should you be alerted to the possibility of refractory anemia. And there are a whole lot of causes which can actually explain, starting from the inadequate dialysis, the various hemoglobinopathies, so many other factors which are applicable to the general population, but more relevant to our dialysis patients are the things like hyperparathyroidism. But the most important, as we all would agree, is the inflammation on the role played by infection. So with that in mind, let us see whether the unmet needs in CKD anemia can appropriately be addressed by the new kid on the block, that's HIF-PHIs. We know there are problems with ESAs. There's an increased risk because of the increased viscosity, especially if you have to use very large doses of erythropoietin to achieve a given hemoglobin target. You could actually be in trouble. So with that in mind, let's see how can HIF-PHI help our patient. And before that, let's again recapitulate our knowledge of physiology. In normoxic states, as you can see, HIF-alpha is hydroxylated by pruryl hydroxylase, and finally there is a ubiquitination and proteasomal degradation by the wall-heparin proteins. Well, in the cases of hypoxia, the pruryl hydroxylase is inhibited. And now HIF-alpha can dimerize with HIF-beta, get translocated into the nucleus, and stimulate or activate the target genes. And in this case, we want the erythropoiesis gene to be activated. But the problem is, this is not going to be the only gene. There could be a few other unwanted genes also, which may get upregulated. And that's why we have fear while using HIF-PHIs, which are going to, even in the normoxic stages, going to inhibit pruryl hydroxylase and thereby allow the HIF-alpha and HIF-beta to dimerize. So when we look at the other genes which can get upregulated, we are looking at what can happen to VEGF or the oncogenic potential of the genes which also can get stimulated. We'll come back to that a little later when we try to see the safety of HIF-PHIs. But as far as the theoretical concept is concerned, on one hand, the HIF-PHIs, they improve on the absorption of iron from intestine, both at the level of DMT1, the divalent metal transferase enzyme. At the same time, by inhibiting hepcidin, this allows the ferroportin to cause absorption. At the same time, it helps in the transport of iron to the bone marrow cells, and of course, physiological production of erythropoietin, which is what we want. And that's why we've become excited in these molecules. There have been more than one molecule, including the one from our own country, the new chemical entity in the form of decidustat, and they vary. All these molecules vary in their targets, whether it is the pruryl hydroxylase domain 1, 2, 3, and also the enzyme, the metabolic enzymes involved will finally take care of the dosing schedule of these individual molecules. So daprodustat, vadadustat, and molidustat are given once daily, while roxa and decidustat are given twice a week. And as I said earlier, this depends upon the metabolizing enzymes. CYP2C8 is the primary enzyme responsible for daprodustat, roxadustat, and redustat. And while the roxadu and decu are pan-PHD inhibitors, while the other three molecules show relatively higher activity on PHD3.
Dinesh,
Well,
Dinesh, can you hear me?
yes, sir, I can.
So there is a request that there are a few questions which are important because of your vast experience of the use of HIF-PHI. So we have chairpersons and we would want to have a little clinical interaction with you. Is it okay?
That's perfectly fine, sir. That's perfectly fine. Can I wind up in 2 minutes?
Sure.
So I think the phase 3 studies of HIF-PHIs in the non-dialysis dependent CKD population showed that you can expect ferritin levels to go down, hepcidin levels to go down, and that's why we are so excited about these. And the summary showed that you can expect significantly higher increase in hemoglobin, and they were found to be non-inferior to ESAs. Similarly, the results were seen in the dialysis-dependent CKD population, and we had a similar kind of experience when compared to ESAs in maintaining the levels between 10 and 12 grams. And these are the various randomized trials which have shown that in these 19 published trials that they ameliorate renal anemia and rectify iron metabolism in the short term without increasing the incidence of AEs or SAEs. Now, coming back to the matter of pride for the country that an Indian company has come out with a drug which we have been able to use for a little over a year now. Desidustat, they had conducted trials in both non-dialysis as well as the dialysis dependent study population, and in both it was found to be non-inferior compared to the standard of care in the treatment of anemia in patients with CKD who were either not on dialysis or even when they were on dialysis. So I am cutting it short, but suffice to say that they were found to be non-inferior in all the aspects, but certainly they had a superiority when it came to reduction in the levels of hepcidin or even the cholesterol level. So that's the additional advantage of these. So whenever we set about using a drug, I think the most important thing is to keep in mind the safety. And with these also, as I said earlier, the issues were whether we are going to see more of retinopathy, or more of cancers, or more of liver disease, or more of cyst enlargement. The answer is, so far, we have not really experienced that in the various trials, but trials are trials. They're in more controlled fashion. And I always believe that the real world evidence is going to shed more light. But so far, we have no major concern while using these HIF-PHIs. The problem with roxadustat was possibly dose dependent, but I think the jury is still out. The occurrence of cardiac or kidney related adverse events in the HIF-PHI groups were not different compared with the standard of care. So that's why these are the recommendations by the Asia Pacific Society of Nephrology, that the strategy is when replacing ESA with HIF-PHIs, you can consider HIF-PHIs as alternatives to ESA in correcting and maintaining hemoglobin levels. But of course, you have to first ensure that the iron stores are replete. So looking at the potential benefits, of course, and this is quite important. On the left-hand side, as you can see, the oral route is a big advantage. It increases or maintains hemoglobin levels effectively, increases endogenous EPO production in physiological range, regulates hepcidin, improves on the iron absorption and the transport. It inhibits HIF-PHD reversibly and transiently. That's the advantage. And of course, the additional advantage that I referred to of lowering of cholesterol and avoiding of supraphysiological or toxic levels of EPO, and one can potentially avoid intravenous iron in these patients. However, the potential concerns have been as related to malignancy, retinopathy, liver function, hyperkalemia. Well, we do come across higher incidence of hyperkalemia and metabolic acidosis to an extent, pulmonary hypertension, but majority of these issues so far have remained theoretical. But as I said earlier, real world is going to give us the actual answer. So, well, what did we do in our patient? We started him on Desidustat 100 milligrams on alternate days. Over the next 3 months, hemoglobin has improved from 7 grams to 10.5. He's not requiring any blood transfusions any longer. The ferritin levels have come down from 1200 to 550 nanograms per ml. So to conclude my talk, anemia is widely prevalent in patients with CKD, as we all know. The current care has been addressing the iron supplementation and, of course, the ESA injections. The ESA hyporesponsiveness is a big concern in a sizable subset of the dialysis-dependent population. At least there is an unmet need with current therapy, and that is when we have recently become excited about the potential role which HIF-PHIs can play in these patients. So I'll conclude, and I'll be happy to answer whatever little I have learned from my own experience, and I'll also request the others to chip in, sharing their experience as well.
Thanks, Dinesh. May I invite the chairpersons, Dr. Sandeep Mahajan from Delhi, Dr. Anupama Vaije from Shimoga, Karnataka, and Dr. Asim Thamba from Mumbai to please come on the dais and take this forward in terms of HIF-PHI and refractory anemia management.
Thank you, sir, for the wonderful talk on HIF-PHI, which is a current new drug which is available for the management of patients with anemia and CKD. For a long time, we know that iron and ESAs were the only two drugs that we were having for the management of patients with anemia, and now the new drug offers some hope, especially for patients, as you rightly pointed out, in patients with inflammation and functional iron deficiency. We can hope some new changes in the new drug may give some new hope to the patients. And I also, as you rightly pointed out, it may take some more time for the other concerns of malignancy to be in the picture, and it might take many years for this new data to come in, whether this can cause more malignancies, as we have already usually see with some of the drugs. It may take many years for the other adverse effects to set in, and as along with the new, when we start using it more and more often, then we'll see the adverse effects. So as regards how do you propose to change over from ESAs to these new drugs whenever we have problems with management of anemia in these patients?
So that's a very pertinent question, I think. Before we jump on to the conclusion that erythropoiesis, the ESAs are not working, I think we need to be fair to them as well. They have helped us in the last 3 decades. So the most important thing is whether the patient is iron replete or not. That's I think point number 1, which is extremely important. And number 2 is if there's an obvious cause of chronic inflammation. Unless you exclude that, there's no point. And we do believe that HIF-PHIs will take care of hepcidin, but they are no magic. I mean, obviously, if there's ongoing loss of blood, or if the iron is still not replete, I don't think they will be able to be that effective. But yes, on one hand, having used the drug in a number of patients over the last more than 1 year now, we're quite excited with what we have been able to achieve with the drugs. Yet, I must confess that there are problems, and there's a learning curve. There would be patients whereby the target would be achieved within no time, and that also scares you at times. In the others, it takes longer, and we are trying to figure out as to what could be the cause. That's on one hand. Then, as I said earlier, you can expect some degree of mild side effects which are easily manageable. Things like mild hyperkalemia or slight worsening of acidosis is something which the nephrologists are best positioned to take care of. But at times, I must confess that even HIF-PHIs may not be able to give you the desired results. So that's something which we will need to follow. So I think our first aim at the moment is to look at the safety data. So before we really get more excited about the drug, they must be safe. And you rightly pointed out the malignancy potential will need a number of years before we are very sure about that. And secondly, is there the scope for innovations? And by innovation, I mean not just a dose of HIF-PHIs, but possibly a combination of HIF-PHIs and ESAs. And that's something unexplored area. So Sandeep is smiling. Sandeep, please.
Yeah, that's what I wanted to ask Sandeep, whether your take on whether you switch over from ESAs to HIF-PHI, taking out all the iron deficiencies, B12, etc. But otherwise, if somebody is not responding, do you switch over to HIF-PHI, and whether you add HIF-PHI to an existing ESA or not? Your take on it.
As far as the safety concerns,
Mike. Yeah, just talk inside. Yeah, loud.
There has been actually no study, there is no data to have a simultaneous use of HIF-PHIs with the ESA. As Dr. Khullar would say, unless we have the science behind it, we can't use it. Though theoretically, it looks a very interesting and a very promising option that you give ESA and you remove the functional iron deficiency part and the inflammation part by giving HIF-PHIs. But unfortunately, none of us would have experience because that has not been tested, that has not been actually looked at clinically. The other important thing, which is especially true in our country, is the dialysis adequacy. So at times, we are so much concerned about iron, B12, folate, we forget the most important elephant in the room, and that is dialysis adequacy. So unless you dialyze these patients adequately, you won't get the hemoglobin levels up, whatever ESA doses you might use. So the first thing is to look at assess recirculation, to look at the frequency of dialysis, maybe add hemodiafiltration if hemodialysis is not working. These things do actually turn around and increase the hemoglobin. But currently, if you have to use, in my opinion, it would be either HIF or ESAs. It can't be both unless we have a scientific data on that. Dr. Khullar, what's your take on that?
Thank you so much, sir.
Yeah, certainly, Sandeep, I totally agree with you, because when I talked about innovations, and I think I basically wanted to bring up the point that even after HIF-PHIs, your problems are not going to end. This is another weapon in your armamentarium. Probably you are better equipped in 2023 to manage anemia of your patients, apart from all the factors which we're already taking care of judiciously. But yes, maybe in future we probably have to think of combining the two, but please be cognizant of the fact that we are on one hand worried about malignancies, and you could actually be getting in the trap of the same, not just malignancies, but VEGF and other things. So I think let a properly conducted trial address that issue. But so far we are excited because many a patient where we were struggling to treat the anemia of our patients, both on dialysis as well as in a small subset of non-dialysis dependent patients, HIF-PHIs have proved to be a boon.
Thank you so much, sir and chairpersons. We close the session for the want of time and move on to the next session.